Hi, Dr. Latini.
Hey, Daryl, how are you?
I'm good. Thanks for asking. Hope you are too. Um, can you tell our audience what you do and where you do it?
Sure. So I'm a clinical psychologist. I'm currently based in Houston at Baylor College of Medicine and in a private practice called Real Talk Psychology. And I work a lot with medical patients. In the past, I've done quite a bit of work with prostate cancer patients and bladder cancer patients, and in particular have worked with prostate cancer support groups for gay and bisexual men.
Right. And long time ago, decades ago, who knows how many hundreds of years, you agreed to let your group be part of the Malecare system. And that was super, and undoubtedly dozens, if not hundreds of men were helped as a consequence of that. Let's talk about that a bit. What were some of the things you learned from running a gay men with prostate cancer support group?
Sure. So quite a lot, actually. I was working for UC San Francisco Department of Urology at that point, and Dr. Carroll, our department chair, had mentioned that he had some gay men in his practice, and he felt like they were struggling a bit, perhaps more than the heterosexual patients, because there was so little information, and they didn't really understand how having prostate cancer surgery, prostate cancer radiation, et cetera, might affect them as gay men in terms of their long-term sex life. Many of them were not partnered and so could use some support. So he asked if we could set up a prostate cancer support group, and I said, sure, I'd be happy to. I learned after, I guess, doing a little bit of looking at the literature and Googling and so forth about Malecare. So I was really happy to connect with you and to understand that there was really a network nationally of support groups. Probably at that time, maybe half a dozen cities. Hopefully, I imagine there's more now. But at the time, there was not anything like that in San Francisco. And so we started the group, and it varied. I would say probably the most would be about 17 people in the group, and probably the least 5 to 6. I facilitated the group for about a year and a half, and then left San Francisco to come to Baylor College of Medicine, and began working in 2007, I guess, with the Montrose Center, which is the LGBTQ plus community center for Houston, and began facilitating a group there. Ran that group from 2007 to 2011, and then left that group to go back and work in San Francisco for the Department of Veterans Affairs.
Super. And yeah, I mean, before just as of March 2020, we had 82 live groups.
Wow, that's great.
Yeah, it is. I mean, it's so gratifying to know that men are showing up to help themselves, and that if people like you and I have any influence on that, that's super. And COVID obviously put an end to all of that. So we have a couple, I think we run 4 massive virtual groups right now. That encompass most of those people and new ones. Hopefully we'll get back to live groups sometime. Good that you led them. What did you hear from guys talking in the groups?
Sure. A lot of things. I've been working in prostate cancer quality of life research for several years at that point for UCSF in the Department of Urology. And so one of the things that I noticed is that there was literally nothing in the literature about gay men and prostate cancer at that point. If you went into PubMed and did a search for gay and prostate cancer as search terms, you came up with, I don't know, maybe half a dozen articles about prostate cancer written by a guy whose name was gay, which was not particularly helpful. So we really knew nothing in terms of the research about, have there been studies done? What's the prevalence of prostate cancer among gay men? Is it more or less than among heterosexual men? How does it impact quality of life differently, et cetera? So what we started doing is, in the group, we were talking about lots of different issues. I would say that one of the things that came up quite a bit in the San Francisco group was that men didn't really understand how to come out to their potential partners as having had prostate cancer. They talked about the importance of being sexual in their relationships with romantic partners, obviously with more casual partners as well, but prostate cancer had a substantial impact on their ability to perform sexually and their sense of themselves as a sexual being. Many of the men, because of the age range that we were working with, had also lived through the HIV epidemic. And so they talked about how terrible it was to have lived through the HIV epidemic, lost so many loved ones, and then to now be facing what was potentially a life-threatening illness like prostate cancer, and to have to go through that perhaps with friends that, fewer friends they might have had pre-HIV. And so, just a lot of loss. And then as people began to shift and talk about how their sense of self had changed, how their sense of themselves as a sexual person, how it had changed their sexual repertoire. So for many men who had originally been inserted partners, that wasn't really possible anymore, in part because some of the erectile dysfunction treatments are not sufficient to create an erection that's firm enough to penetrate someone anally. And so they talked about having to, flip from being tops into being bottoms. And again, that really changed their sense of themselves as a sexual being. One of the things that I think was really important that I guess I sort of knew intuitively, but to hear it over and over again in the groups was the importance of being able to ejaculate. For example, there was a gentleman in the San Francisco group who joined the group with his partner, and he had chosen radiation as his treatment in particular because the radiation oncologist assured him that he would still be able to ejaculate after having treatment. And unfortunately, probably a month or so into treatment, he lost the ability to ejaculate. So you might say, well, why is that so important for us? And we talked about this in an article that we wrote later on during our research program. But I think it is that for so many of us, because of HIV, ejaculate became this kind of taboo thing that, you weren't supposed to share ejaculate, et cetera. And also for all men, gay, straight, bisexual, whatever, being able to ejaculate visibly is that kind of sign of completion, sign of satisfaction with the sexual activity that you've had, et cetera. And so I think it's really important as a component, a very visible and very important component of our sexual activity. And to lose that, in addition to losing the ability to have a dependable erection or losing the ability to have an erection at all, et cetera, those kinds of things were very impactful to people. And I think that because of the frame of reference of their presumably primarily heterosexual physicians, they had no clue that that was going to be so impactful for their patients.
Yeah. And I mean, I'm not as big an investigator as you are or any of our friends in terms of massive paper writing, just a few dozen. Actually, I'm up to 30 or 40 now. But the idea of ejaculate was like my first paper in 2003 or 4 and got published in 2005. The idea that ejaculate play is significant as well. It's not just like an identity thing. It's just a pure visceral joy,
Right.
between partners or when masturbating. One of the things I learned from doing the earlier gay men and prostate cancer support groups was there are many gay men who have never had sex with another man.
Mm-hmm.
There are many men who, they're absolutely gay in their, this is their presentation, this is who they are, their authentic self, but they're virgins, or not, if for lack of a better word is probably a more appropriate way to say that, but masturbation and ejaculation is part of the gratification they experience by themselves as gay men without partners, and that loss is excruciatingly painful for them. Yeah. Yeah. What do you say to people who, the heterosexual people who say, but all of that's true for, straight guys?
Well, I mean, I think there are a lot of responses to that. One is that straight men are more likely to be partnered. For a gay man who is looking for a new partner, either casual or longer term partner, the inability to ejaculate is going to really impair the experience of their partner in terms of their having sex with a partner, being able to attract a partner, et cetera. And so I think it's more important for us than for straight men. And if you have a partner, if they've gone through prostate cancer treatment with you, I mean, they're kind of there for the long haul. And so the fact that you now can ejaculate but you're still alive is going to be a substantial, well, hey, honey, I don't really care because, I still got you here. We're still together, etc. But for many of the men in the support groups, both in San Francisco and Houston, they were not typically partnered. And so the group really became a real source of support for them, but also they were clearly looking for partners. And how do you tell somebody, well, I'm a 50-year-old man, and I used to be a top, but now I'm a bottom and I can't ejaculate anymore, and, et cetera, et cetera. So, I mean, there's a lot of kind of caveats that you're going into a sexual situation with, or a longer term relationship with, that straight men just don't have to deal with. And, I've heard many wives of heterosexual men with prostate cancer say, well, I don't really care because it's less messy. And, for us as gay men, it's like, we want the mess.
Yeah.
Yeah.
Yeah. No, I mean, and that's true. I mean, that's how Prostate Cancer Foundation of Australia came to partner with Malecare, because of that very phrase. Wonderful man whose name is, I know his first name was David. I'm struggling to remember his last, but absolutely wonderful heterosexual guy with his wife in the audience doing a presentation in New York City, saying, basically, it's go have surgery, you won't miss the mess. And his wife sort of giggling, and afterwards we spoke, and that was, I sought him out in the audience, and it was like, he and, his wife didn't have a clue the significance around ejaculate. In many ways, ejaculate is more significant than erectile functioning. Imagine if prostate cancer surgical interventions, maybe, just 100% fail rate for erectile functioning, but 100% save rate for ejaculate. We may not have this kind of psychosocial issues that we have.
Yeah.
What do you think the barriers? Well, what did you hear about barriers to access to care from the group? I mean, did any of the guys feel just out and out discriminated against, or how did that play out?
Well, surprisingly, even in San Francisco, there were many men who were not out as gay or bisexual to their providers. And as we know from work that many people have done around, and actually some of the studies that we did later, if you just are not going to have as good an experience with your provider if they don't know your complete health picture, including your sexual health, sexual orientation, et cetera, all those kinds of things, because how can they advise you on what you should be doing, when you should be doing it, et cetera, post-treatment, if they don't know the fact that you're gay? And, these are the things I like to do in bed, so when can I do them again? So I think that's really important, and sort of leads into some of the later research work. I was very fortunate to work with a dear colleague, Tay Hart, and also with folks in Australia, Jane Usher and her group, to do some studies where we tried to check out some of these things. And is this something that other people experience, or is this just some unique experience of people who go to support groups? And what Tay and I found is that there was lower treatment satisfaction among the men in our study. Now, granted, our study was, I think, the first of its kind here in the US and Canada. It was very difficult to recruit people. We ended up with 92 people in our sample, and it was extremely difficult to get those 92. We really had to fight tooth and nail to get people in the study and so forth. I'm not exactly sure why, maybe shame around having cancer or something like that. I don't know. But in any event, the issue of a great deal of concern about ejaculation and lack of satisfaction with care, and feeling like you're connected to your provider and they're giving you the best care that they can, all those kinds of things we found was much less when we compared our sample to other samples of presumably heterosexual men, because of course none of the large prostate cancer disease registries at the time, including the one that I worked on at UCSF, actually included a question about sexual orientation or gender identity or any of that kind of stuff. None of them did. And so we were comparing our data in a very broad way against these other samples, assuming that most of the people in those other samples were straight, but they could have also been gay or bisexual. We just didn't know.
Yeah. How do you think your research has changed the simple intake forms that people have done?
Well, I think it definitely reinforces the idea that GLAMA and some other places, other organizations have talked about, where you really need to be much more sensitive in terms of asking about sexual orientation, gender identity, partner status, and so forth. And of course, we were doing this in, I think, 2009, maybe 2010. And so this was way before gay marriage, et cetera. So there's been a lot of conversation in society about issues around LGBTQ relationships, et cetera. So I'm sure it's different in part because of that. But I think that the idea of being able to bring your male partner to your doctor's appointment, certainly some people in San Francisco were doing that, but I think that if you're not comfortable coming out to your doctor, you're certainly not going to bring your male partner. And if you walk into the receptionist office and the receptionist asks about, well, is your wife going to be in the appointment, sir? Obviously, that's going to affect how you feel. You don't feel seen, you don't feel taken care of, you don't feel known, et cetera. And you're at an incredibly stressful point in your life where you're trying to make decisions that are going to have huge impacts on quality of life, both physical and psychosocial. And some middle-aged receptionist person who is probably very well-meaning is asking you about your wife. And so it just kind of adds insult to injury.
Yeah, and it doesn't have to be a middle-aged or receptionist person either. And I should, GLAMA is not a makeup brand. It stands for Gay and Lesbian Medical Association.
Okay.
Would, so within like LGBTQ plus medical clinician type people, healthcare providers, Gay and Lesbian Medical Association is, I guess, the earliest, or certainly one of them, to sort of collect the medical community around our people and sort of, you know, find ways to advocate for everyone. The idea of doctor, though, it's not just doctors, it's nurses, it's support staff in hospital settings. You meet with a radiation oncologist, but it's a radiologist that actually is performing the procedures, turning the machines on and making sure everything's calibrated. It's, endless receptionists and secretaries, and then people behind the scenes who are, now inputting electronic health records, but in the glory days of the early 2000s, it was handwritten for the most part. And if they saw any designation for gay, you have to really wonder, like, are they going to screw around with it? Probably that never occurred, but the fear of that occurring was always top of mind or close to top. So you've had a really good, appreciation of gay, bisexual men who enjoy sex with men and relative to their experience of prostate cancer, both listening to them in a support group setting around table and also investigating them, which is to say surveying them, interviewing them, looking at their records, and then trying to synthesize some sort of understanding that's never been understood before, and then publishing it, so that lots of other folks can do that. What do you think from your career are like, top 1 to 3 or 1 to 5 highlights that nobody really knew before you got it on paper?
Well, I think the difference in treatment satisfaction was a big deal that we found. I think that, again, your paper in 2005 about ejaculate, but we heard it from a much broader range of people. So I think that underscored that and has been validated in many other studies, the ones with Jane Usher and some of the other stuff that's been done in Australia, Richard Wassersuck's work, et cetera. So I think those are important things. I think the impact of prostate cancer on a middle-aged or older gay or bisexual man who's lived through the HIV epidemic, again, it's a further insult to their sense of self, their sense of mortality, their sense of community, and really their ability to be a marketable quantity in the relationship market and to meet new people either for casual relationships or for longer term partnerships. In some cases, I would say guys feeling like damaged goods and so unwilling to go put themselves out there in terms of looking for a new partner. And so I mean, I think those are really the most important things. I think that I was also surprised, although it's not an empirical finding, but surprised at the resistance that we met in trying to publish our initial study. So we submitted our study to a couple of urology journals, which I won't name, and we got really unfriendly, let's say, reviews of, we already know this, why are you doing this study? Basically, who cares? And of course, again, if you looked in PubMed when we started doing our work, as I said, there was nothing on gay men and prostate cancer, zero. So how could a reviewer say we know all this when there's nothing in the literature? Maybe you know anecdotally from your clinical population, but you don't know from the research literature, and you don't know what the prevalence of this is, and so forth. So I was surprised and disappointed that we met such a unfriendly response from the reviewers.
Yeah, and that continues to some degree today. I mean, there's always reviewer number 3, and I love the jokes around reviewer number 3, but on papers I've co-written with, not lead lead author, but I've seen the reviewer number 3, like, why are you doing this? This, and it's, I mean, 2022 right now, and we're still struggling. I put an essay in the ASCO Connections thing just last week, describing how after 23 years of being, and doing a social worker, patient advocacy kind of thing, it's insane we're still having this conversation.
Right.
So tell our patient audience why research for our community is particularly important.
Sure. So let me go back to the first LGBTQ cancer conference that we started organizing in 2005 in San Francisco. And the Gay and Lesbian Medical Association was going to have their annual meeting in San Francisco in 2006. So we partnered with them, and our conference was a 2-day meeting. The first day we partnered with GLAMA, and it was for clinicians and researchers. The second day was held at one of the community centers in San Francisco, I think the LGBTQ Center, if I remember correctly. And it was very interactive with patients and people doing spoken word, people doing dance performances, people doing musical performances of their experience of being cancer survivors and cancer patients. So it was very impactful. But on the day that we met with the Gay and Lesbian Medical Association, really at that point, only Uli Bomer from Boston University was doing research work around LGBTQ populations and cancer. And so, to be honest, the rest of us just kind of sat around and said, we don't really know. We think these are probably the issues, but we have no research at this point to describe what it's like for gay men with prostate cancer, what's it like for lesbians with bladder cancer, et cetera. And so it really highlighted the fact that there is no research out there, that you have to be able to have research data that you can point to, whether it be for hospital administrators to say, this is why we need a gay men support group for prostate cancer patients or cancer patients in general who are LGBTQ, because these data show that there are big impacts on quality of life. And if you ignore this population, you're really doing them a disservice. So that's one of the reasons why research is important. And also, I think that having worked with a lot of patients with prostate cancer, both gay and straight, I have a pretty good sense of what I think is going on with quality of life, with psychosocial impacts, mental health concerns, partner concerns, et cetera. But as an individual clinician, I don't know if my population is unique. I mean, you could certainly argue that gay men in San Francisco are different than gay men in, say, a small city somewhere else in the country. But the research really allows you to pool larger numbers of people and to look for patterns and trends that might say, wow, this is something we see across studies in the US and Canada, or across studies in the US and Canada and Australia and these other countries where culture is different, socioeconomic situation may be different, the social situation for people who are LGBTQ may be different in these other countries. But here are these common themes that we see So the fact that we see these common themes across a broad range of populations means these are really important and we need to pay attention to them. It's not just Dr. Latini's unique people in San Francisco who look a certain way and everybody else doesn't have that issue.
Yeah, and this is an argument, a suggestion, and a compelling reason for everyone listening to this to, when you see a call to action, an email from Malecare or anyone else really, saying be part of a study, if it's just do it. I mean, certainly if it's a medical study or involves medication or therapies or treatments, ask your doctor and on and on and on. But if it's just, an inquiry into your thoughts and behaviors and understanding of life vis-a-vis prostate cancer, please just do it, and most studies now pay a couple hundred per shot. So that's kind of cool too, you know,
Sure,
and you're welcome to donate that back to Mailcare,
sure.
Yeah.
It's a way for your voice to get out there and to join with the voices of other people. It's a way for you to take action from your couch, sitting there filling out a survey. You don't have to march in the streets, although if you do that, we'd be happy about that too. But it's really a way for you to speak your piece and to have your doctor and other doctors around the country and other countries and nurses and other healthcare professionals really hear, this is what's important to me. And it's not just me, it's all these other people in the study as well. So yeah, please join research projects.
Very well said. But I mean, the idea of being active from your couch is brilliant. Um, I want to quote Jerry Perlman, who and Jack Drescher, who also said, if prostate cancer is patients are an invisible population, then gay men with prostate cancer are even more invisible. I forget what smart way they put it, but the point is, activism from your couch is just as critical as marching in the street.
Yeah.
Before I say goodbye and hello another day, like any helpful hints, any top level kind of like takeaways that you could offer people listening right now that'll make them, happier and such.
Sure. Well, I guess what I would say is a lot of times people feel like they're alone and they're dealing with things that cause a lot of shame. Even people who are partnered, for example, there was a couple, a male couple in the San Francisco group, and they were really struggling with a lot of issues that were coming up between them. They weren't talking to each other, et cetera. So at one point, they had stopped coming to the group for, I don't know, 2 or 3 meetings, and I reached out by phone and they said, oh my gosh, thank you so much for reaching out. There's all this stuff going on. We're really struggling. It's hard for us to talk about it, et cetera. So whether you're partnered or whether you're single, reach out to people, join a male care group, join other groups in your area, look at resources online, talk to people, don't sit and suffer in silence by yourself. Take action, get the resources and support that you need. Great.
Dr. Latini, thank you for all the great work you've done. Thank you for being a pioneer in the field of LGBTQ plus psycho-oncology, being part of the field when it was just LGBT, and yeah, hope to see you again. And I'm sure our patients will continue to benefit from your research.
Great. Thanks very much. I appreciate the opportunity to speak to folks.